he is going to teach us how to create an ice pack, right?
So if you
just believe it, knew it from the start.
All right. Well, joy is an incredible alarm clock, and I am joyful. That's a quote by John Acuff, one of our favorite authors around here. And I'm incredibly joyful that we get to speak with two of our favorite pals and friends from Pearl Health today. We have Michael Kopko. He is the CEO of Pearl Health, and we have Ankit Patel, who's the co-founder and president of Pearl Health. And we're going to put in the show notes Pearl Health, all the links to how you can connect with these gentlemen about what we're going to be talking about, which is direct contracting and the nuances of that. And so if you're a doctor who is taking care of Medicare fee-for-service or traditional Medicare members, then this is going to affect you whether you're paying attention or not. So this is a really important subject we're going to cover today. And in a nutshell, 50% of Medicare members or Medicare patients and traditional are Medicare Advantage, but also more traditional medicine are involved in that, are still Medicare fee-for-service. Direct contracting is a CMS move for many of the remaining Medicare fee-for-service patients into value-based care. And today we're going to be talking with Michael Kopko and Ankit Patel from Pearl Health. You can go to pearlhealth.com, and they're going to help us understand what this is, why it's around, how it applies to your practice directly, how your patients, how it impacts your patients, and then walk us through some of the nuances and finer points. This is actually part 2 of our interview with them. You can go back and listen to part 1 with Michael and I from just a few weeks ago. I'll put that in the show notes. And we acknowledge that there's a large educational need for more information, and you are experts in this field. And so we're pleased to bring this topic to you guys, and we wanted to help doctors who are listening, reading, whether you're maybe listening to this on Spotify or iTunes. You can go back and look at the presentation here at our links in the show notes, as well as on YouTube and conciergemedicinetoday.org. But we want to help fill this knowledge gap for you. So direct contracting part 2 is kind of what we're going to be talking about today. So gentlemen, thanks for being with us.
Thanks for having us. Great to be here, Michael. And great to be on the program again.
Absolutely. Well, I will let you guys go ahead and kick it off. You guys have a few slides that you're going to share that will help frame this conversation today. So I'll let one of you two go ahead and kick it off. And again, our guests today are Michael Kopko and Ankit Patel, the senior leadership over there at Pearl Health. You can go to pearlhealth.com.
Yeah, Michael, it's great to be here. And I'm really lucky to have Ankit, who I've been working with for quite some time now, who's really a master of understanding around value-based models. But, in short, for those listening in, the shift toward value-based care is going to continue. We're very excited because Medicare is enabling these advanced models to come into traditional Medicare. And we think there's a real opportunity to not only bring physicians into this world, but actually change how they're practicing medicine in a better way. And so Ankit's going to give you a little bit of introduction on some concepts that we think are going to become a part of reality for physicians across America in the coming years. And we're really proud to be building a software layer that will help make that transition for them. I'm going to let Ankit just introduce himself because he's got a fantastic background for this. And then we'll kind of just get into the few concepts that we think every primary care physician across the country should not only be aware of, but be excited for in the coming change of direct contracting and shifts in Medicare.
Great.
Thanks, Mike. Really nice to meet you. And to Michael, my co-founder, it's been great working with you. And just to give a little background on myself, I started out as an attorney working inside of a healthcare system in-house counsel, had an opportunity to really get exposure to how integrated delivery systems are delivering care and all the legal issues that came with that. I left that very shortly after starting, only practiced law for 2 years, went to go work at Medicare during the Obama administration, worked at Medicare itself, and had a chance to work on a number of payment models that were intended to help the healthcare system, physicians in particular, transition towards a value-based care approach. With our focus at that time was, if we could bring Medicare along, could that help the physician community and the commercial market sort of start transitioning to value-based care as well? In 2015, I left to launch a Medicare Advantage plan with a group of founders that were really kind of thoughtful about how they wanted to bring value-based care in the MA space. And my role there was sort of twofold, working directly to build out the primary care network. But at that time, we had started a model to do capitation and built a software layer that could help physicians operate in a capitated value-based care model. Was there until 2019. And then once the direct contracting program was announced by CMS, was very excited to kind of explore that, started talking to the physician community about it, and then got connected to a group of investors who were excited about investing in our software and platform. And Mike and I have known each other and had a chance to work together, and we've been running at it pretty hard over the last year, and has been really exciting to see the traction and the excitement that we've had both in the physician community, but then both also in the healthcare community writ large, who've been interested in learning more about it, and really have been excited at the prospect of this being kind of the next phase of the value-based care journey.
Wonderful. And so you've got some slides that are going to help kind of fill us in on some of the finer points of what you guys do and what is direct contracting. And we'll let you go ahead and kick it off.
Great. So I'll start us off here and talk a little bit about the world that we've been living in today in the fee-for-service environment. And, for many physicians, we know that we're operating in a world where you're on an assembly line, you walk into the office, in the waiting room, there's already kind of patients that are lined up, and it feels like you're just sort of trying to, tread water, keeping up with all the patients who are coming in who need care. And physicians are operating in this world where, in order to kind of generate cash flow, they have to do these 10-minute, 15-minute office visits for which they bill services. They earn probably $83 on average, what we see in Medicare, for seeing a patient for 10 minutes. Now, what we know the reality is, and I say this as family members who have practiced primary care in the US, I have, just by way of my background as well, on a personal note, have family members who practice medicine in Europe in the NHS that just has a fundamentally different model for supporting and paying primary care doctors, is that you often have these patients that come in, they have the cold, they probably just need Tylenol, 24 hours of bed rest, see if the fever breaks. But what ends up happening is that there's this incentive and this demand for everyone to come in for this in-person office visit. And you do we've all as patients been to the doctor's office, you get your height, your weight, your blood pressure, you sit in the exam room, doctor comes, checks you up, and then you're sort of out the door. And given the stress and the demands that are being placed on the primary care physician community today, with an aging population, a growing population, increasing demand for healthcare services, it's just not a sustainable model for a physician who's trying to properly deliver care to the community. For that patient who just had the cold, probably a text message would have sufficed, maybe even a FaceTime phone call, maybe a conversation with a nurse practitioner. But the reality is that practicing care that way, that probably is more efficiently allocating the resources that the doctor has, probably a better experience for the patient, probably allowing for better healthcare outcomes, is not rewarded, because the only way the doctor is getting paid today is, again, bring them in for the visit, do that 15-minute checkup, send them on their way, and now I'm getting paid $83. Over the last couple of years, you've seen that the government has tried to create more complexity around, we're going to create this new billing code, and if you build this one code, we'll pay you for this thing, and build this other code, and you're going to get paid for another model. I think, interestingly enough, what we have really seen, particularly in the concierge community, is that creating some stability in the revenue is unlocking the physician's ability to use their best judgment, to rely on their knowledge of the patient and the clinical needs to deliver care at the right point of care in the right method. And so what Mike will show here in this next slide is that it's really about converting physicians to operate more in a portfolio management model. I have some patients who are utilizing the healthcare system at a cost that's over $100,000 per year. I have another set of patients who cost less than $1,000 per year. And let's just be clear at the outset, cost is not the only thing that we care about, but it can be a very nice proxy for helping us to identify who are the patients who are using healthcare, have a high level of healthcare needs, and are interacting with the system. Once you can get to a model where the doctor is not dependent on having to do, again, these $83, 15-minute office visits where I'm kind of just churning on an assembly line and kind of moving through my day as quickly as possible. But now I've gotten some revenue stability. I got kind of a fee that's coming in. I can now dedicate my time, my resources to the patients who are most in need. There's some patients who need a 10-minute visit. There's some patients who need a 2-hour visit. There's some patients who you can see through a virtual visit through technology tools that are now being built out. There's some patients that you actually need to see in person. How do we get to a model and get to a place where the physician and the clinician can use their best judgment to allocate their resources to determine what's the best way for me to meet these patients based on their need, and in the way that's going to deliver for them the best experience that's going to give them an opportunity to improve the healthcare outcomes for their patient panel. Again, the concierge medicine community has already kind of gone down this route. They've already figured out ways in which they can kind of create some revenue stability and to create that concierge touch so that they know when a patient really needs that 2-hour visit, they've set their practices up to allow them to do that while also being able to meet those patients and really just need a quick 5-minute phone call, text message, or even a 10-minute in-person check-in.
And Michael, part of it, and the doctors listening in, we think that this model not only enables a better, allocation of our resources as a country, but that attention part that Ankit mentioned is very important. That, in the current fee-for-service model, often to get attention, you have to keep escalating your costs so that you get the right physician and facility engaged. And we think that primary care layer has the opportunity to give attention and, frankly, deliver great outcomes when it matters most. But it's actually the payment model and the alignment that prevents some of that. So we're really excited about this new shift, and didn't mean to interrupt, Ankit, but I think, this is a true change that's coming to the primary care practice of medicine as we know it.
Is this going to impact family medicine doctors who are seeing seniors as well?
Yeah, so this is going to cover family medicine, internal medicine, geriatrics, any sort of primary care physician can be included in this direct contracting program. And so Michael, it's a great segue. So let me talk a little bit about the kind of direct contracting mechanics. And in this next slide, what we'll see here is we'll talk a little bit about how the management of a provider panel operates in direct contracting. So just to kind of give a little bit more context on how the direct contracting, in our minds, is really truly moving Medicare towards essentially concierge medicine. The direct contracting program is doing a couple of things that we think are pretty exciting for the primary care community. But the most important component is that it is eliminating the fee-for-service model and converting revenue for the physician who are accepting Medicare patients into a full capitation subscription-like model so that the doctor is now getting a fixed per member per month for their Medicare patients. So the way this would work is just imagine you have sort of Dr. Patel has got his outpatient clinic, and normally he sees Medicare patients. They come in, we're back to that sort of old assembly line. I'm going to see the patient, do my quick visit. I've got a whole bunch of other patients waiting in the waiting room. So let me get this done as quickly as possible. I'm going to bill, what would be, just to keep it very simple, let's just say the 99213 E&M office visit code is send that to Medicare, and then Medicare sends me $83. All that goes away now. That bill is $0. You're no longer getting paid for the bills, for those primary care bills that you were sending into Medicare. And instead, what Medicare is saying is we're going to give that doctor a fixed dollar amount each month for that patient. And I'm going to make the math up here just to so I can do the calculations kind of easily in my head. Let's just say we're talking like $50 per member per month. We're talking about getting to, on average, about getting, let's say, $600 per year for that patient. And now what's going to happen is the doctor no longer has to worry about whether the patient comes in for a visit. I just know that I'm getting that guaranteed revenue. I'm getting that kind of stability, which now allows the doctor, as I kind of described before, to manage the patients and the panel more holistically in the way that kind of matches the patient's needs and allows the doctor to kind of follow their clinical judgment. So what this then translates to in terms of how you can really be successful and think through how to manage the full kind of panel. The direct contracting program brings an element of financial risk alongside that capitation. So what the program does, it says, in addition to your fixed per member per month, in order for us, Medicare, the government, to ensure that you're not just going to take that kind of per member per month and kind of hit the links and be out on the golf course all day, we want to create some accountability measures so that you're going to get a bonus payment or potentially, to be transparent upfront, a potential penalty payment based on the patient's outcomes. So if a doctor is successfully generating positive health outcomes and lowering utilization, the doctor is going to get a bonus payment. If it goes in the other direction where patients are not being managed properly, they end up having poorer health outcomes, end up utilizing the healthcare system more, the doctor will have to pay a penalty back to the government. All that's to say is that what we know is that at least within the concierge community, the data sets that we have available to us, we're pretty excited at this prospect because that community generally has shown to have much better healthcare outcomes for their patients, in part because the doctors who are out there listening know that they're already under a model where they're spending the most amount of time for the patients that they need. They know that when a patient is discharged from a hospital, I need to go see that patient and spend a full hour with them to understand what caused them to go to the hospital in the first place. How do I follow up with this patient over the next 60 to 90 days to make sure they don't end up in the hospital again? So a lot of the kind of what we're describing and talking to doctors about in writ large is already kind of old hat and familiar, probably to a lot of the physicians who are listening in on this podcast. But one of the things that we are noticing can happen once a doctor moves into this type of model, and even when we talk to physicians who are already operating that concierge model, is yes, I'm a doctor, I'm managing my panel, I've got a lot of care coordination that I'm doing, but I've got some patients that are just difficult and tough for us to kind of think through. One is I've got a patient who is past the point of, I was managing them at CKD stage 3 and stage 4, but now they've entered into CKD stage 5. They may have gone to kind of full-blown ESRD and renal failure. How do I manage that patient? How do I coordinate with the nephrologist to ensure that I'm the primary care doctor, but I need other support services to help manage that ESRD patient? I've also got potentially a dual eligible patient. For those who are not kind of familiar with the lingo, these are patients who are eligible for both Medicare as well as Medicaid, and are generally identified as patients who have a lot of kind of additional complex needs, and they need other support on addressing some of the social determinants of their care. They oftentimes lack transportation services. They have hard access to healthy foods and pharmacy to kind of get their medications. How do I manage those patients? One of the things that Pearl is trying to support through our technology as well as our services layer is that we want to bring some of these additional services to these doctors who are operating under direct contracting in this kind of concierge model, where we can go to the doctor and say, we know that you're doing a great job. We know that you've got this clinical model. If you need help on some of these more difficult to manage patients, we've got a network of other care service providers who are experts in helping to coordinate for your ESRD patients. They're experts in helping to kind of manage your musculoskeletal patients, helping to coordinate with a network of orthopedists, skilled nursing facilities, working with kind of home health agencies that can deliver physical therapy services in the home. And we really want to be kind of a technology link that can help kind of bridge that concierge medicine doctor to these other services. It's all optional. All that's to say is that if the doctor feels like they're already covering these patients and have already got a model, we don't want to disrupt what they're doing. But put Pearl to the side. One of the things that I would say to kind of any physician, whether they're concierge or not, is entering into the direct contracting can be a really exciting opportunity to kind of create a new clinical workflow, but would also note to the physician community, would really encourage everyone to think about who those downstream providers and service partners could be to help you manage some of those more complex patients who have a very specific kind of clinical need within that given period of time that they're entering and participating in the program.
Great.
And so I'll let Mike add his additional thoughts, but we'll also kind of transition to the next slide kind of as we move into the next topic here. Great. So what you can see in the slide here is the way in which we think about direct contracting and the opportunity for physicians. And there's really three things for any physician to think about as they're contemplating participation in the program, is that there are, as I mentioned, three components. There's a fixed per member per month capitated payment amount. There is a potential shared losses, kind of what I described as a penalty, where if your patients actually end up doing worse and your care quality does not improve, you would have to pay a penalty or what the government will call shared losses back to Medicare, or there's kind of a bonus payment, which they describe as shared savings, in that your healthcare utilization for your patients has gone down, their healthcare outcomes have improved, and so you're sort of getting this bonus payment. And every doctor has a different preference in terms of where they want to be and how they kind of want to play in this program. There are a lot of entities and organizations that are actively participating in direct contracting. Pearl has a model where we really think that this should be a choose your own adventure approach for doctors based on where they are in terms of their clinical practice and their clinical model. And what that means is that there are some doctors who really just want to dip their toe into direct contracting. It's a new concept, it's a new model, and they want to test it out. And so we at Pearl kind of create an arrangement that can be a very kind of entry point for participation, all the way to some physicians that we work with are very familiar. I imagine that this is probably more the audience that is out there today who are very familiar with concierge medicine, understanding how to kind of do high touch, high engagement with patients who have a higher level of clinical needs. Those doctors will say to us, we're very excited about taking more of a bonus payment. We want to go very risk forward. I'm happy to put me on a penalty program with more bonus and more opportunity, because I already know how to be successful in this type of model. And what Pearl says in this approach, and we would recommend that any doctor, whether it's Pearl or not, who's talking to a potential DCE partner, to consider the three kind of components, which is, what is your fixed per member per month? What is your dollar amount that you're getting? Is it $40, $50, $60, maybe $100? Just depends on the market and the partner that you're speaking with. And then what is the amount of shared losses that you are willing to take on? How much penalty will you take? And then how much bonus payment do you want to have? What Pearl says to the physicians is, we're happy to create any sort of construct that makes the most sense for the physician. So I have some doctors who will say to us, I don't want to be exposed to any penalty program. It's a new concept for me, but I really like the idea of a per member per month payment instead of and I want to get off this fee for service kind of hamster wheel. We will say, great, we're happy to do that. We, Pearl, will give you a much higher per member per month. Pearl, will take on all the responsibility for any penalty payment. So you, doctor, will never have to take any penalty payment. But for our part, on the Pearl side, we will take more of the bonus payment that is earned when we get a bonus payment from the federal government. So what that could look like is, you're not going to get any penalty payment, but if there's a bonus payment, Pearl will take 75% of the bonus, and you, doctor, will get 25% of the bonus. In other arrangements where the doctor is maybe a little bit more interested in taking a kind of riskier arrangement, we'll say, great, we'll give you maybe 90% of the bonus payment in exchange for you taking 25% of any potential penalty. And then I've got some doctors who are very risk forward, and they'll say, you know what, I want you to cut my per member per month payment, the capitated amount, all the way down to $25 per member per month. I want the whole enchilada on the bonus payment. I want to take full 100% shared savings, and you only need to pay me $25 per member per month. The point that I make to the physician community is, as you find these DCE partners that come around, whether, again, Pearl or any other entity, really want to encourage the physicians to really negotiate with these partners and really understand where their risk preferences are and what they think is going to be a best kind of arrangement. For Pearl, again, we're kind of creating a customized approach, and our goal is really to let doctors dip their toe in this program, because we really think it's an exciting opportunity for the community writ large to really enter into the model that the concierge community has sort of already figured out, and for those who are already in this concierge model to really step on the gas and figure out what's the best pathway and the best arrangement. And what you see here on the screen is we've got the ability to pull data down that's de-identified data. It's not patient specific, but to give kind of a free analysis. When a doctor approaches us, and again, we'll do this for any physician, they come to us, they tell us what their NPI is. We run the numbers based on access to the Medicare data systems that we have been able to pull. For those who kind of want the technical language, it's the chronic condition warehouse that Medicare has made available to the community. And we can kind of give an estimate to say, based on your historical performance on your Medicare patients that you've been seeing in the past, we can kind of give an estimate as to how your performance would have been in both 2018, 2019. We do 2020, but we generally tell folks it's a little bit of a wonky year given the pandemic and all of the challenges that we faced in that calendar year. But can really kind of say, if your practice had been enrolled in a direct contracting program in 2018 or 2019, here's what your performance would have looked like. And here we've kind of pulled, we haven't shared the physician's name, but this is kind of real kind of data and information that you can see here. And you can see that in 2018, if the program had been live, the physician would have generated, had poorer, kind of lower outcomes, would have generated a penalty payment. But in 2019, they would have earned a bonus payment. And this is with a physician. This was a non-concierge kind of medicine doctor who was really not paying attention, and wasn't on this kind of capitated per member per month model. But we think that there's a real meaningful opportunity, and we've identified here that what we've seen is that they've seen some specialty services growth and utilization has kind of increased year over year. We think that there's an opportunity for the doctor there to kind of explore maybe why their patients had been seeing more specialists than they had in previous years, and also noted that this physician had a patient panel that was going into the inpatient hospital setting more often than the other physicians that were in their community. And what we think this allows us to do, at least when we do this analysis for physicians, is we're helping them identify what could be the right arrangement for this doctor. It may be that they're not they've had some kind of erratic performance in the past because they weren't properly incentivized and weren't in this kind of concierge-like model. They may want to do a contract and an arrangement that's a little bit of a dip your toe. I don't want to take any potential exposure on penalty, but I am excited about the opportunity of generating sort of a bonus payment, and really like the idea of getting into this per member per month payment. And so happy to kind of, as I mentioned, do that type of construct, but then also talk to them about where their opportunities would be going into 2022 of really focusing in on those patients who are utilizing specialists for their care. Now that you're on this kind of concierge model, doctor, who's never done this before, how can we start getting and identifying those patients and seeing if you can spend an hour with that patient so they're not, utilizing and going to the cardiologist for what is something that could have been addressed in that primary care setting.
And Michael, one of the things we're really excited about here, there's a lot of kind of financial discussions because these are businesses that you can't upset. In fact, you have to think the other way of how do you get them additional returns. But, stepping back for a second, this is really an opportunity to reorganize the delivery system around primary care. And that's what we're really excited about. And, the panel that we showed right prior to this screen, really shows that with primary care physicians able to participate in models like this, they start becoming kind of the leadership of the Medicare panel and are really kind of helping not only engage, but then partner with physicians who can help manage the conditions before they get to the hospital or before they get to the very critical part of the system that winds up driving all these costs. And so a lot of our time is spent making sure that this financial transition is a positive one. But what we're most excited about is this kind of as a representation of the future, that primary care physicians and other physicians who really are the community health leaders that we all know and love can help direct and manage the care for their communities, and now can start building the not only financial tools, but the network and management tools that we're kind of used to on the health plan or insurance side. We can start kind of equipping and empowering the primary care physician with those.
Wow. So really what I'm understanding and seeing is they can kind of log in on any given month, quarter, day, and kind of see. I mean, you can forecast this out just similar to even like you get the numbers up front before you decide to do this. You can see if this is going to be successful based on past history. And this will kind of give you a forecast of, okay, this is going to work for me. And I can move around the graphs and the percentages. And if I'm willing to take more risk, if I'm not willing to take a lot of risk, this is that what I'm understanding is they can kind of, it's all the numbers all at once through the pearlhealth.com.
Exactly. And we do that for free, and we are very transparent. So you can see what the program would pay you. This is not, our fees in there or anything like that. This is just what you as a physician would be able to achieve if you were participating in this model. As we scale and grow, we're going to commit to adding more data sources so that estimate gets more and more accurate. And we want to make it free for especially our independent physicians, because they've got a lot of things on their hands as it is. And we think the market is missing an honest, kind of trusted advisory partner who can help show them what these programs would mean for their practice. And all they have to do is just confirm their MPI, and we can deliver these results to them. No other commitments required.
Wonderful. And our guests today are Michael Kopko and Ankit Patel of Pearl Health. You can go to pearlhealth.com. Before we jump on to the next slide there, Ankit and Michael, the traction that you guys have, the response from physicians out there. Maybe you're going to talk about this in the next couple of slides, so you're willing to put a pause on my question. But what has been that response? What has been the traction, the results of that? And if that's a question you're going to answer in the slides, go ahead and say, "Yep, I'm going to cover that here in the next couple slides."
Well, just want to answer the question up front. It's been incredibly positive, and we've been very successful out of the gate. We've got over 300 physicians participating in our program already. We've got 16,000 Medicare members to date that are part of Pearl's platform. I think more importantly, though, physicians are eager for a change. The treadmill of the primary care job is a little bit exhausting, and it doesn't really enable them to practice the things they were trained to do in medical school and even prior to that in terms of their career goals. It's become a little bit of a game around generating that next billable unit. And we're very excited to kind of liberate primary care physicians and other physicians who are similarly minded so that they can practice humanistic, holistic healing, and that they don't have to trade off economics as a result of that. And we think, the primary care, the concierge medicine communities, even frankly, the direct primary care communities all get this. Coming from a health plan background, the biggest problem in making these shifts is a money problem. You've got to move the money to these models. What Medicare has done, and we really want to congratulate them for it, is they've enabled this kind of a shift as a government payer. We think there's going to be a lot of private sector commercial payers that are going to see the results of these programs and eventually start to shift as well. So we think we're in the early days of a change, but we think that most physicians are going to be excited in participating in a model like this in the years to come. And I'll kind of just show you a couple more slides in terms of just what that kind of financial story looks like. But what we're really excited about for physicians in general is this change of work, helping move them to more of their top of license, engaging, challenging problems each day, as opposed to how do you kind of perfect and game a billing system that's become so complex you need to hire a whole administrative staff just to manage it. I'll let Ankit kind of speak to these last kind of remaining slides quickly, and then happy to take any questions, from you, Michael, or from your audience. Ankit?
Right. So as you see here, kind of what we've been discussing is the model that we can forecast for physicians. I mean, Michael, I will say that in our experience, regardless of where a physician's kind of past historic performance is, we think that everyone is a great fit for this type of program, simply because of the power that this kind of concierge medicine model brings. And we tell any doctor, regardless of where they're starting from, just go talk to any physician who's been operating in the kind of concierge space. They'll tell you how much better their experience has been, the patient's experience has been, and kind of how much better the kind of patient's outcomes have been from a health perspective. And what we do here and what we can see is that there are a couple of components that allows us to track, because Medicare has done such a great job over the last decade, quite frankly, of building out the architecture to make data more available and more visible and more accessible, is really to help the physician in real time understand what is happening with their patients and with their panel. And we do this kind of live with doctors. And so at the top here, what we can show is that there's a kind of stability in payments that you see in this kind of first bar graph in terms of the revenue that comes when you have kind of a fixed per member per month. The only fluctuations that you really experience there are when a patient moves away, they're no longer your practice, that you were living in New York, now they've kind of retired and moved to Florida. And so you're kind of no longer getting that kind of PMPM's kind of subscription fee, from Medicare on behalf of that patient. And then what you see is, for this doctor in July, kind of Medicare has made this kind of bonus payment because they've reviewed all the data from the previous calendar year and said, yep, Dr. Kopko has done a great job managing his patients. Healthcare utilization has gone down. These patients have kind of better health outcomes kind of measured by these quality metrics. And then what we can see in real time to help the doctors kind of track towards generating those bonus payments is, what does the spending look like month over month? And do you see an uptick in terms of, are your patients utilizing more healthcare this month than last? Are things trending in the right direction? Obviously there's some seasonality. People tend to get more sick in the winter months than in the summer months. And then we can kind of do a comparison year over year to see kind of how things are performing and whether you as a physician under this program are starting to see an increase in your patient's utilization. What that means is it allows us to kind of come in and give a notification to the doctor to say, hey, it looks like your panel is starting to go see, spend more time in a skilled nursing facility, or you've got some patients who are going directly to a specialist, wanted to give you a heads up, let you know that there's an opportunity here for you to kind of bring those patients into your office or have some type of engagement that can maybe get at understanding kind of why this patient may be utilizing more care than they have in the past. And then, of course, at the bottom there in this slide, you can see we're trying to distill that down into kind of very clear and kind of actionable items, where what you see here for this particular physician is in their panel that patients are spending less time in the skilled nursing facility. And that's, a good thing from our perspective, is that it means that we're discharging, getting them care in the home, and helping them spend more time in their community, more time with their family. And maybe that means that it's because of this kind of concierge type model that's allowing them to connect with the patient for what a physician traditionally would not get billed for. Maybe the doctor's out there, having the kind of practice connect with them virtually in a video call, maybe connecting with a care manager, or maybe even a spouse that's in the home. And that we're seeing that we're, decreasing in hospitalization rates, and but at the same time, for this particular doctor, increasing in the number of specialist referrals, which again can be an okay thing if that means that we're getting specialists as opposed to kind of them unnecessarily utilizing the hospital. And so if we go to this next slide here, this is kind of the physician view, at least what Pearl builds for physicians to be able to see on their particular panel. What we're trying to do is kind of give an overall view for what's happening for the physician, total number of patients that you're actively managing right now, what the patient NPS score is. And so based on survey measures, how do the patients respond to the model that you're transitioning to, or how they kind of like this kind of concierge medicine approach. And then what we do is we're kind of letting you see what's happening with your patients. You got 3 patients that are inside a skilled nursing facility right now. One of your patients has been recently hospitalized. And then you got 25 patients on your panel that we think are, priority patients who have had some kind of recent healthcare event that we think warrants kind of additional interaction. Really, who are the ones this month and on this day that really need that kind of concierge touch right now? And then in those priority patients, you can see the top 3 that we've identified. Based on the kind of risks that we're seeing, we're pulling in data that we get directly from, again, Medicare is providing this data to us. We're pulling in data from lab companies, pulling in data from kind of various EMR sources, and really understanding what is it that's triggering us to say, hey, doctor, this is kind of a high priority patient. Let us help you kind of bring them in to kind of get them inside of your care model, whether it's in an in-person visit or in some other setting or other kind of way for you to connect with them. We've got patients here that, one patient's got elevated glucose. We know that they don't have access to transportation. Let's talk about how you, doctor, can kind of get that concierge touch to that patient, so we can make sure they don't have some acute event that puts them inside of the hospital. And then
one of the things I'm just wanting to add in terms of the audience listening in is, this is kind of something that really hasn't been done before, and giving physicians, and not only at a cultural level, but at an infrastructural level, the type of information to holistically manage a patient panel. If you speak to any physician who's been in kind of insurance contract or a commercial arrangement, the war to get data that's usable is a war that's almost no longer worth fighting. It's incredibly hard. The healthcare system is not well designed around this. And what we're building is a way for to open up the aperture and the opportunity for physicians to participate more holistically in their patients, and kind of treating it like how the relationship really began, of one between patient and physician, not treating physicians like cogs in a wheel that we're trying to just kind of run them through certain services and then understand at the insurance level or wherever it may be what's happening, and keeping that information to ourselves. We have a passion for opening up this information to physicians and letting them be more holistically involved in the healthcare of their patients.
And Michael, that's a great segue to kind of the next item that I want to talk about here, which is a lot of you may be thinking, in that screen, and Mike, if you just want to go back to kind of on that last screen there, there's a lot of kind of quote population health tools out there, right? And what's different about direct contracting, what's different about kind of what you guys at Pearl are building and talking about. And I think that the thing that we have learned, and the reason we're excited to be able to build sort of a new product from scratch, is that all of those existing tools, one way or the other, are trying to plug into a fee-for-service billing system, right? That they all say that I'm giving you population health metrics, I'm kind of stratifying your patients. But at the end of the day, what they're trying to do is kind of eventually get back into what is a code that I can build, right? What can I send to my insurance plan? How can I kind of package this together to send to Medicare so I can bill something and get some revenue. And the nice thing about what we're able to do is we're out there talking to physicians. We've got designers and our technology teams working with the physicians and just asking the physician, forget about the money, right? Because we've already figured out a way where you're in this kind of concierge model, you're getting a fix per member per month. What do you want to see, right? We're showing data, and we've got data analytics from our perspective. We're not the clinicians. I can just show you from the data perspective. These are 25 patients that we think are high risk. Do you agree? Do you not agree? A lot of them are giving a lot of insights, and they've said to us, I need to have the ability to remove a patient from the priority list because all these population health tools tell me here are the patients I need to care about, but I know that this list is wrong. Great, let us know. We'll resurface that. We'll change it around. And then the other piece to it really is you, doctor, you tell us what you want to see. And we're very happy to kind of build that in and start understanding when it's no longer about how do I kind of package this in a way to get revenue and a code that I can send to an insurance plan, but really just focus in on what is the clinical needs and what is the information I need to see. We've been able to build that very quickly. And it's kind of the most exciting thing for us about direct contracting. This is the first time that we feel like as kind of technologists, we can build something based on what the clinician is asking for, not what the health plan is telling us we need to submit in kind of based on their rules and regulations.
Wow. Well, from a patient perspective, looking at this and looking at all that we've talked about this kind of globally, we've talked a lot about what the physician's perspective is. How are the patients reacting to this type of arrangement? Is it changing anything within the confines of the exam room?
Yeah,
so are they noticing anything?
Yeah, so it's a great question. And I think that where we are right now is the program has just gone live for a group of physicians who started participating on April 1. There's another group of direct contracting entities who will be kicking off in January 1. The initial feedback that we have received from a handful of physicians that have kicked off in April 1 has been very positive so far. The patients like the fact that there's more proactive outreach that these physicians have been doing. They like the fact that they're no longer sort of sitting in feeling like they're spending more time. The metric here is you're spending more time in the waiting room than you are in the exam room. And a lot of these practices operating in this, the equation has been flipped, right? I'm spending less time in the waiting room, more time in the exam room with the NPs and with the physicians who are managing my care. And we're excited to kind of see that grow and to scale and see how we can kind of continue to make the patient experience more enjoyable, quite frankly. And then the other piece that I'll note is that Medicare, as part of the program, is their oversight. They are calling patients and doing surveys to get the patient's response and feedback, and they're going to be scoring and measuring the physicians based on, one of the things that you saw on the screen that Pearl is building is that NPS score to make sure that the patients are having a better experience than they were in that fee for service. And we're pretty confident that it's going to be better because but the government's kind of doing their due diligence to say we just want to make sure that if we start moving and adopting this concierge model in Medicare, do the patients like it as well?
Well,
Sure,
I would just add,
absolutely.
Michael, that it's the early innings here, and we're going to learn a lot because data takes a little bit of time to be studied over time. But I think the biggest transition here is you've had a completely unmanaged patient population in traditional Medicare. There really is no active management, and when you think about sending someone who especially has complex conditions through the healthcare system, and that they're in the Medicare state or the retired state, that can be a day's work just trying to get your appointments lined up with the right physicians, et cetera. And coming from the world we came from, Medicare Advantage and commercial plans, that there are a lot of failures in a world where no one's proactive about managing that patient's journey. And I think this program should and will, at the end of the day, lead to a lot more investment in managing patients through their journey. And I think it can be led by the primary care and other physicians associated with them, so that we don't lose patients along the way, and we don't have patients having to go to very expensive places in the healthcare system simply to get attention.
Absolutely. I remember talking, it was about maybe 2 years ago with a doctor face to face, and he stopped me before the conference and he put his hand on my shoulder and he said, I just am so amazed at what this physician community, that is the concierge medicine community, was doing for the Medicare members specifically. And he just said, this is changing their lives. And it literally brought tears to his eyes and almost tears to my eyes as he continued to say, this is so important. The work that they're doing for the Medicare community is so invaluable. And it's changing the way that that these lost individuals, these forgotten in many cases individuals, and some are very proactive. Hopefully, wife is prodding the husband to say,
Let the notes flow like a symphony. Now I can say things differently.
It's a really great thing. You've got an idea, you've got a medical practice, you've got patients who come in and out, but that thing that you want to do called concierge medicine, there's a learning curve to it. Do you want to accept insurance? Do you want to participate in Medicare? Do you want to do a hybrid practice? What's your staff going to look like? Are you going to incorporate different tests inside of the office? And if you're interested in me speaking a little bit of truth to you, and sometimes it's not as easy as we think. We want somebody to just say, oh yeah, you can do this right away. It'll take you like a week. Sometimes we don't really want to hear that. There's a learning curve to this. And the speakers that you're going to hear, the presentations and courses that you have access to within this community are here designed especially for you. Please. Questions. We have a few questions for you. We talked a little bit about the patient perspectives. And before I jump off that lily pad, your second to last slide there kind of had some graphs that were pretty much holding steady. And then there was another graph that was also pretty much holding steady. Let's go back to that just a second. So let's say that we're looking at the payments, and then we look at the total spend per member per month, and we start to see that payments are going down, but the spend is going up. Are we going to start, because that's the rub or the tension might exist when we think about new types of things that we want to incorporate in the practice. Is this is going to equate eventually, and then might take a year and a half to get there. But I'm just trying to think about the naysayer in the back of the room who's processing, has had some bad experiences but for the most part, he's like, well, what if the payments go down and the spend goes, or the necessary time and my involvement goes up? Is this going to happen? I know it's premature to look at the data just as early as it is. But what's your forecast? What's your thoughts on that? I'll let Ankit, I'll let you tackle that first, and then Michael, I'll let you have your 2 cents as well.
Yeah, so a couple of things I'll say at the outset. We love the naysayer docs, because they've got a lot of experience on what has and has not worked. We sympathize kind of with those experiences. I mean, at the outset, the model itself for direct contracting, to speak to that, is a voluntary program, right? So you have the opportunity to join. There's no obligation from the government at this time to have to commit to it for a 5, 10, or period like that. But we think it's a meaningful opportunity to kind of give a test to what would it look like if Medicare were to align its kind of payment models to the concierge model that you've already sort of kind of experienced. So that's sort of kind of the first answer that I would give. I think the second piece that I'll say, it's a completely fair question, right? I mean, there's kind of two pieces here. One is, how much am I getting paid? And what, again, whether it's Pearl or anyone else, always need to kind of worry about what that dollar amount is on the per member per month payment, whether it's going up or down. I can only speak for Pearl, and we'll say that we will always be very transparent, and we will show you the numbers on a month over month basis. And so we're not trying to create any sort of surprises where you're in, and then all of a sudden year 2 arrives and things have kind of fundamentally changed, and all of a sudden the dollars have kind of gone away. But I think there's a second component to this, which is that it's just how you're getting paid, right? Moving away from fee for service towards this per member per month. The thing that doesn't oftentimes get talked about is the administrative costs that practices are absorbing right now. There's a lot of studies that are out there, but the number generally tends to converge around 15% of your fee for service revenue is going to the administration of the billing, the rev cycle companies, all these kind of different components that take a slice of the dollar as that bill moves from your EMR up to the health plan. Sort of a lot of that goes away. And we think that's kind of a second component that makes it a very attractive proposition. But yes, in the interest of full transparency, the name of the game here is improving healthcare outcomes. And we're pretty confident that, while there is some risk that, healthcare outcomes go down and the dollar amounts go down, and there's exposure to kind of a risk and kind of what I described as that penalty payment for not improving outcomes, we are yet to see, Michael, to your point, when you talk to these doctors in this concierge model, that things don't get better. And the kind of point that I'll make there is the way Medicare has structured this program, they're looking at a blend of the regional rate and your historical performance against kind of what you're doing in your current performance rate, we feel very confident that a doctor who adopts a concierge model is always going to knock it out of the park relative to the other physicians in the community who are still operating in that kind of fee-for-service kind of hamster wheel. And so we want to be very transparent and expose the numbers and very much talk to a doctor if things don't seem to be going in the right direction. But at the same time, we've got a lot of confidence and conviction, having talked to a number of concierge medicine physicians, that this is the right model that is going to, give a lot of positive outcomes for both the physician and the patient. And I'll let Mike, my co-founder, kind of speak to kind of his perspective on this as well.
Great.
Yeah, and Michael, I know we're coming up on time with your audience, so I'll be brief. I think the big thing with these types of comparisons are you've got to have a relative assessment, meaning compared to what? Fee for service has its own risks. And not to say that there isn't some kind of a transition and some risk here, which we're very, analytical and just transparent about, but it's not an absolute where you're comparing it to some platonic ideal. You're comparing it to a fee for service model, which has gone through some tremendous shocks as of recent, and we'll go through it again. We care much more about revenue stability in these models. And I think the most important thing we're focused on, and it really is an individual choice for your physician out there, which kind of mental model do you want to wake up in every day? How many fee for service, billable units can I generate, and how efficient can I get at that? Or do you want to start participating in a world where you're responsible for the healthcare of your entire panel and their holistic journey through the healthcare system? And coming from the health plan side, I was really surprised at how far the primary care physician had been pushed out of the equation. And we want to restore a lot of that autonomy, dignity, influence, and frankly, the empathy that comes from your primary care office, nurse practitioners, et cetera, into the healthcare system, and take it away from kind of the big billings and almost at this point automated facility game that really dehumanizes the experience for patients. And we're all going to be in Medicare at some point, and our children will as well. And we think this is an opportunity to restore the primary care layer in that delivery system. And that's what we're most excited about. And we don't want any physician to participate in it that's not excited about it as well, because we want it to be a mutually rewarding experience for all of us.
Absolutely. And it seems as though your mission is met immediately with momentum. And I've got a few more minutes and a few more questions still. So if you guys have got about maybe 8 or 10 more minutes, we'll rattle through these questions if that's okay.
Sure.
We love that.
So, bouncing off of the lily pad of the patient perspective onto the day-to-day administrative burden that you mentioned, Ankit, what type of day-to-day interaction am I going to have, with DCE, with a DCE or with Pearl, to monitor what's happening? And it's a kind of a two-part question: administrative burden, administrative needs, day-to-day, happenings. And then the second part of that is engagement term. What if I see that the numbers aren't, and I call you and we're working with your team and the numbers aren't looking where I want them to be 3 months in, like term and termination? What are my options? Like, what's my engagement length? Or what if it's like, it's time for me to jump in? Nothing crushes a discussion like a decision. So how do I get in? How do I get out? And what's my daily interaction look like?
Yes, let me start with kind of getting in, getting out, and then I'll kind of talk about the daily engagement, and we'll let Mike kind of share his perspective on the daily engagements as well. Getting in and getting out is pretty straightforward. I mean, right now we're happy to talk to any physician who is interested in participating in the program. We're working with a number of DCE partners across the country in any geography. And as Mike mentioned, we're happy just to do a free analysis. I mean, you don't have to join a DCE, you don't even have to go with Pearl, but you kind of come in with us. We're happy to kind of give you an overall view on your practice, kind of what's been happening. A lot of doctors have been interested just in understanding what's happened in 2020, kind of given, the pandemic. And the best way to do that is if you go onto our website, it's pearlhealth.com, just kind of fill out your name, your information. We'll get your contact and we'll be able to kind of reach out to you and schedule a time to pull the numbers. And again, we're pulling actual sort of numbers from Medicare, giving you a kind of profile on what's been going on in your practice from 18, 19, and 20. And again, a lot of folks have just wanted to know kind of how 2020 was different from previous years, kind of given everything that we all went through during the pandemic. And I think getting out, it's an annualized contract, but happy to kind of have a termination provision. And we've worked with a lot of physicians who've asked this very question. For a lot of them, what we've recommended is if you're in that early stage of just entering into and wanting to dip your toe into value-based care, we've sort of offered a kind of arrangements where there's no kind of downside risk or exposure to them, and have structured a contract where, it's all only exploratory, it's all upside only. We've structured it in a way where we there's no physician yet who hasn't said it's at least worth exploring this for at least 1 year's worth of participation to see how this goes. As we all know, there's always fluctuations. You end up getting an early flu season, a late flu season, a good flu season, a bad flu season. Every doctor knows that can kind of fundamentally change what happens month over month. We always encourage everyone to stay in for a full year, and we've structured arrangements and contracts that would allow them to do that. And from an engagement perspective, our hope is to kind of meet the doctor where they are. We've talked to a gamut of folks who've participated in, ACO-like structures, and some of them complain to us that the ACO is talking to me too much and trying to get into my flow, and all they do is tell me to do AWVs, annual wellness visits, and kind of complain and tell me I need to do more annual wellness visits without any explanation on why I need to be doing that. Versus other end of the spectrum where they say, I never hear from these folks ever again. I signed a contract and they sort of disappeared. What I can say from Pearl's perspective is, at the very least, our goal is to have a software layer that no matter what, you can always see real-time information updating inside the software. You'll always have someone to pick up the phone and call, but we've also kind of built in a chat function where if it's easier for you just to do it on your phone, iPad or on your computer, you can always chat with us and just kind of get in right there, instantaneous. We've got folks kind of responding kind of real time. And then our hope, though, in addition, is at least on a quarterly cadence at the kind of physician schedule, let's just sit down, talk about how things are going. We want to make sure we're getting feedback so that as we kind of continue to improve our model, our engagement, our software, we're doing it with physicians' input, not just us kind of sitting in a room by ourselves thinking that we know best. But Mike, you have anything else to add to that?
No, I mean, I think that's really well said. We are not pushing people to participate in this model if they're not comfortable. We care most about the tools and technology we can give to providers so that they can win in the next round of the healthcare revolution. It's obviously going much more digital, much more distributed, and physicians have to change their practices to kind of keep up. And we want to partner with like-minded physicians and make sure not only are their economics still intact, but that we can accelerate their practice opportunity in a changing world.
Well, thank you. And the next question has come in that is about adjustments of risk. How is this similar to, like I meet with my certified financial planner, my AIF, and I can make adjustments once a month, even though he or she might advise, no, you need to stick it out, man. So what is the types of engagement layer there? How often are you guys making the tweaks? If I call you, is this something that has a set term for the term length of the engagement? As far as risk, or is like, yeah, I'll take more risk this month. Data's looking good.
Yeah, so we right now contract with physicians and do annualized arrangements. We have not yet had any physician ask for sort of a midstream change. We're happy to explore that. What we kind of, to my point on, the erratic nature of a flu season, ask physicians not to get too excited when numbers are up for just 1 month and not to get too down when numbers are down for 1 month. We really think that the best way to assess how a doctor's clinical model is working is to really kind of follow the patient for a full calendar year and to really understand kind of what those trends are. All that's to say is that we're very committed year over year to kind of help the doctors, let's call it kind of redo the arrangement that they have that's in the best interest for them. Again, we're trying to be very transparent with our numbers. If you're kind of doing really, really well, but you've only kind of taken a kind of dipped one toe in the water, we're very happy to go to a physician and say, we think you should be jumping into the deep end because you're doing great. You're trending in the right direction. And we think that there's kind of a better opportunity for you. And Pearl would be happy to kind of redo that contract at that time.
Awesome. Well, we have 4 more questions. I promise the last one is a doozy for you. It's going to be a positive one. I'll let you start thinking about it. And it's going to be, the last question is, I ask this of all of our guests, is if you were to hand over the keys, and I know you guys kind of just started incubating and implementing, but if you were to, be like, you know what, I want to go spend some more time with my family. I'm handing over the keys to Ankit, or I'm handing over the keys to Michael. You got the keys to the kingdom. if there was one thing that you were to look back on already as far as the success, and you're like, this is why we did this right here, I can go to bed happy and sleep seamlessly. That's the last question that I'll ask you. So I'll let you guys think and ponder on that. But our third to last question, or our next question comes in, and it's asking, what will happen if doctors or I just want to ignore this and let the pieces fall where they may? What are some of those consequences that you think? I know it's tough to put a crystal ball into our centers of our universe, but Michael, I'll let you start first. Ankit, I'll let you move into that next.
Well, I mean, at some level, nothing, in the sense of if you're already in that mindset, you probably are coming with a set of assumptions that new programs have risk in them, and you want to see how things play out. And I think we don't want to put anybody in an uncomfortable position. And so I think there's a world where, you're not going to miss a lot, with the exception that there are going to be several thousands and maybe tens of thousands of physicians that are going to move into this model, and will be a year ahead of this operating model change. And so, I think I'm sympathetic to the physician who's gone through a lot of changes out there, and this is the N+1, as you say in math world. And so we don't want to push those folks over the chasm too quickly. However, I think if you step back and you're just being intellectually honest about not only Medicare and the Medicare Trust Fund and what's happening in terms of the expenditures versus the revenues, a shift has to come one way or the other. A change has to be made. If you've been exposed to the commercial sector, they increasingly want you kind of bought into their economics. And so I think there's this future that value-based care represents. Some have been burned by it, some have been very successful in it. But I think the most important thing is that you at least follow along and keep learning. I think that's the one loss here. I wouldn't say kind of put your head in the sand and pop out in a year and see what's happened. I think there will be some people who lean into this shift and do very well for themselves, and most importantly for their patients, because the whole point of this is to kind of blast away a lot of administrative waste and basically return healthcare to the patient-physician relationship layer, and let kind of software come in and start just making all of those interactions very easy and quick. And so I think that might be the biggest missed opportunity if you don't want to consider participating in this model. But we're not a high pressure tactic group. You're going to be fine. You're going to just model out what your fee for service world brings you. But I would say if you talk to most payers out there, most government payers out there, they see there's going to be an end to that world over time. And so I just think you should keep up with how the programs are shifting at a minimum, so what that will likely look at when the reckoning moment comes, which it does in these shifts to all of us over time.
Yeah, Ankit, I'll let you have the word on that one.
Yeah, no, that's well said. The one note I'll make, that from a Pearl perspective and things that physicians should sort of demand of all their DCEs, I would say, is that we honor our contracts and our arrangements, right? So these programs can, folks who've been experienced with kind of regulatory changes, I understand the concern that things can change. Our goal is to kind of be the entity that manages that change. And so if we told you we're going to give you X, even if the government changes and makes a tweak here or there, we'll still, continue to kind of operate under the terms that we signed.
Wonderful. And the next question, our second to last question here, is from some of the slides that we saw, is how can doctors find DCEs in their area who they might be able to partner with? How seamless is that process for you guys? How quickly does that do an analysis? The numbers are looking pretty good. What's the next step after that? What's the decision? How long does it take? Those types of things.
So you're going to find we're a very transparent group. You can go onto government websites and find all the approved DCEs in the country. We've spoken to all of them, and we encourage physicians, if they want to not take our word for it, but to make the calls themselves. What they will find is there's a whole different grab bag of offerings. What we can do on behalf of Pearl is help you sort through them and kind of get to the best one for your practice, and why we've had a lot of physicians wanting to speak with us and kind of help guide them through the process to date. But you can kind of just go out there and look at the list and figure out what's the best match for you if you think that's a better model for it. It takes a little bit of time to get their attention depending on who they are. But we're always happy to guide you to the right one. And we've had an opportunity to speak with all of them, and we kind of know the different offerings that they provide and have modeled ours to be competitive with all of them, so that you don't necessarily have to make all those phone calls. But we encourage folks to not take our word for things and kind of do the work if they're so inclined.
Great. And our second to last question is I'll start with you, Keith, because of your experience with CMS and working there on different plans. Will there be any changes to the model under the new administration that we have right now? I know that it seems as though healthcare comes in as a wave and then it's here for 3 or 4 months and then the topic moves on to defense or whatever it might be. So I know that's a little bit of, again, of a crystal ball question, but just based on your experience, I'll let you tackle that grenade.
Yeah, look, I think from my experience, kind of having been inside the government, when you have programs like this, they try to keep stability so that the programs don't change, but they will be willing to listen to potential improvements. I mean, I had a chance to work on a number of different models while I was at CMS, Medicare, and we would get feedback from the stakeholder community, and they would suggest a change. And if we looked at it and we understood what the physicians were saying to us, we were more than willing to kind of make a change going into the next year. I don't foresee there being sort of any big kind of shift or upheaval in turning out the model upside down. The other thing that I'll note though is that for us, we kind of view the world through two lenses with respect to kind of CMS. Is that the first is that the government has made a commitment, it's a bipartisan commitment to continue to support physicians in the transition to value-based care. And so we think that value-based care is going to continue to march on, continue to grow, is going to continue to evolve, number one. But two, I think that there's an increasing and growing recognition, both in the commercial side as well as within the government, that physicians need a little bit more stability in order to take on more of the requirements for patient care, meaning that you're getting these kind of per member per month payments, needing to have some type of revenue stability. In other models and other programs specific to ESRD patients, other programs related to oncology care, you're starting to see this notion of concierge medicine, right? It's how do you get a fixed per member per month fee that can then help give the physicians revenue that allows them to do things that may not match may not be something that is a quote billable code, but is kind of meaningful activity that's helping to support the patient's healthcare outcome. We're continuing to see that trend both in the government space, Medicare and Medicaid, but also a lot of these new models and programs that are coming from commercial payers are starting to incorporate that as well. And we're very excited about that transition because again, the reason we're here talking to you is we just know that this is a model that has been successfully kind of implemented by a number of physicians that has really done a lot to help improve healthcare outcomes.
Wonderful. Well, our last question, I've already asked it. It's if you pretty much hand over the keys to one another. Michael, you're going to hand over the keys first in this scenario to Ankit, and he's going to take the reins, and he's like, why? And you're like, because I came here with this, and this is why I did this, and this is my story, and I can sleep peacefully now to know that we have made our dent in the universe, as Steve Jobs would say. So, Michael, go ahead and kick that off.
Well, in truth, I think it's a few years, maybe more, until we can even visualize this moment. But I think we both have a very shared value set around the role of the physician in the healthcare delivery system. And I think we both have been a little bit surprised. I came to healthcare probably 8-9 years ago, a little bit of neophyte, and I'm surprised at how many non-physicians are really at the center of the system. And I think we're very eager to restore, the role of that discipline to healthcare. And I think Ankit comes with all the right values and frankly, the experience that will make him great to run Pearl. And we don't plan to make any shifts in terms of our leadership anytime soon. But I think that physician first focus, and then I think we both share this value around transparency and just doing all of our partnerships cards face up. I think healthcare is a unique industry, and you really have to work with everybody to make the shift and the change you set out to make. And so we are not really playing a game with our partners. We're very upfront with them, and we're always working hard to do the best deal by them because we think it's a very long game that we're playing together, and want to have people leave all of our interactions feeling very positive.
Wonderful. Ankit, how about you? One of the stories that you can remember that's like, this is why we do this.
Yeah, look, I mean, I'll tell you kind of my motivation, and I appreciate the kind of handing over the keys, but I'll tell you, I'm going to be in this for the long haul, and keep kind of moving the ball forward. I had mentioned that my family, half my family is in the UK. They practice medicine in the NHS, and I used to spend my summers in Wales, where I have an aunt and uncle who are practicing medicine out there, primary care. And, it might, I don't think it's too much of a stretch to say that the NHS is, basically running a concierge model in the NHS where, my uncle would practice medicine. He gets a PMPM, he has assigned patients. And I just remember being there as a kid and, loved spending time inside of his practice and kind of following him around. He would do house calls. He had nurses that were employed that would do house calls. He carried his little bag in the trunk and we'd be at the grocery store and all the people in the grocery store were his patients. And he would, if someone wasn't feeling good that week, we'd do a quick checkup right there in the grocery store. If there was an elderly patient who we knew had chronic conditions, he was in a community with a lot of COPD. He was, seeing the patients right there. It was at the park, and I'm not suggesting a world where, the doctor's like, switched on 24/7, but at the same time, there was a relationship that he had with the community that was just so powerful and meaningful. It was the community loved him. He loved treating all of his patients. And it really was truly population health. And that's to me, like, we have a community here that's in your audience that calls it concierge medicine. It's not concierge to me. It is the population health. It's the way in which we all thought medicine should be, and all the kind of terms that we've used has already been happening inside of this community. When I was, and I'll give you an example for myself. I had like a really bad stomach flu, and it was just awful, and I had a crazy fever, and the doctor that I called that I was seeing at the time, I had to go into the doctor's office, and there's no other way for me to go see the doctor unless I physically went in to see them for a 10-minute visit. And I was in the car, my parents were driving me, and I had to pull over twice, because I had the stomach flu on the way there. And it just was, one of the first times I kind of noticed that I'd just gotten back from a summer with my uncle, and it was just different. Like, why is this model here where, my physician or NP or someone was coming to the home, and my family was seeing patients in the grocery store, and how do we bring that type of model here? And it really is kind of what the concierge community has already done. And I'm very excited, and kind of what gets me up in the morning is really just getting people an opportunity to see how we can bring some of those elements into this model. And when you think about the Medicare population, there's no community that needs that type of delivery more than our elderly. We got a baby boomer population that's kind of coming in and aging into their retirement, but we're seeing a growth in chronic conditions, and we really need, more concierge services to this population. I can't be more, can tell you how excited I am to see Medicare moving this direction, and just a warm welcome and excitement from the concierge community, not only to participate in this Medicare program, but really being champions in their community to talk to other physicians who've never seen this type of model, and to let them talk to the doctors and say, here's what concierge medicine is. Here's how, this can be a really great thing, not only for your practice, but for your patients as well. We're just really excited to be on this journey, and we're hoping that, we at Pearl can be, playing our part to contribute on that journey.
Indeed. Well, thank you, gentlemen, for your time today. And, for those about to turn down the volume and move on, just remember, it's not about being the best doctor in the world anymore. It's about being the best doctor for the world, for your patients, and for your local community. And while I am not a physician, I am a patient, and I know what it's like to sit on the other side of you. And I've been to the visits with my mom. I've been to the visits, with senior family members, and it ain't easy out there at all. And so we need more doctors being for their patients, for their communities. And certainly this is an innovation that we're proud to see. We're happy to see. I know that many doctors will be very filled. That knowledge gap is now filled, and they can make a decision. And our guests today have been Ankit Patel and Michael Kopko of Pearl Health. Go to pearlhealth.com. Go check out the analysis. Gosh, it's free. Just call them. If you got more questions, call them, email them, connect with them. They're happy to do it. So, gentlemen, you've certainly brought a lot of joy to us, a lot of joy to, I think, a lot of the physicians listening. Thank you so much for being our guest here today.
Thank you. Really great to be
much.
here again.
It's really nice.